Welcome everyone to 22nd Annual Congress Pakistan Society of Hepatology 2022. I am Dr M Nabeel Shafqat, postgraduate trainee of gastroenterology from Department of Gastroenterology of DHQ Hospital, Gujranwala. Today, I am pleased to present pitfalls in estimating actual HCV seroprevalence in community setting. My co-authors are Dr. O. Chaudhary, Dr. Mishal Azam, Dr. Masuma Bajwa, Dr. Asad Chaudhary, Dr. Najmu Seher, Haris Chaudhary, Aksar Ramzan, and Muhammad Sufyan Tahar. We conducted. Looking at the background of the study, we know that Pakistan is the second country in the world with the highest prevalence of hepatitis C, with more than 70% of these patients being unaware of the infection. Approximately 27,000 people die each year due to the HCV in Pakistan. If we want to achieve the HCV eliminating criteria set by WHO in 2030, we will be able to save around 152,000 lives in Pakistan. But this calls for a large-scale screening and a subsequent linkage to care. First point of contact at a community HCV screening camp is crucial in triaging newly diagnosed and previously exposed patients. Why? Because the seroprevalence of HCV in each area is affected by previously exposed people who report for the screening. A structured interview can help reduce this problem. If we look at the hepatitis C elimination with targeted screening, treatment and prevention, we come to an end that if we want to achieve this goal, the number needed to screen in millions are 18.8 per year, with the number needed to treat is 1.1 million per year in Pakistan. According to the projected health outcomes of hepatitis elimination presented by Hepatitis Policy in 2022, the total infected cases in Pakistan are projected to continue at the same rate, while despite this is contrary to what WHO 2030 elimination program has decided. And the similar misery is happening with the new HCV infection, because our HCV infection, if it goes on the same rate, will eventually increase instead of decreasing by 2030. So in order to achieve the target set by WHO to decrease the total infected cases as well as to decrease the new cases, which is the incidence of HCV infection, we need a large community screening where we screen a patient and get all the patients infected treated. Objectives of our study were to assess discrepancies in the actual HCV seroprevalence caused by treatment experienced patients in the local community screening. With regards to methodology, a universal point of care screening for HCV using rapid tests, we used Biola and Abbott, was carried out in the selected areas of community in DHQ district Gujranwala. The study was conducted in two phases. During the first phase, a public announcement was made regarding the purpose of the camp and emphasizing the need of prior declaration in case of previous exposure. During the second phase, all those patients which tested for anti-HCV antibodies positive in the first phase were recalled and a structured interview was conducted with a special emphasis on prior exposure. In the end, discrepancies between both phases of study were documented and results calculated. Looking at the results, we see that during the initial phase, 680 patients out of total 2,251 were tested positive for anti-HCV. So the calculated prevalence of HCV in the initial phase was 30%. However, during the second phase, when a structured interview was conducted, we found out that out of these 680 patients, approximately 57 percentage of patients, which means that 388 patients has been previously exposed or undergone hepatitis C treatment, while only 292 patients out of these 680 patients were actually newly HCV antibody positive patients. So out of total 1863, only 292 patients were positive for HCV, which means that the actual prevalence was 16%. So we can note that the prevalence decreased from 30% up to half, around 16%, when a structured interview was conducted. We can conclude that a detailed interview can help filtering out previously HCV exposed individuals in the community. This will help preventing an overestimated figure of prevalence of HCV, which leads to unnecessary NAT testing, increased requirement of human resource and finances. Our findings also call for a national database HCV registry, where previously exposed can be filtered out, making use of the latest IT tools. This is especially important when we look forward to achieve the goal of hepatitis elimination by 2030 as set by WHO. Following are the references which were used to conduct and write this report. Thank you everyone.